Okay. Well, my topic today is the Neuromyelitis Optica Spectrum Disease. It begins with Eugene Davick, that was the discovering doctor in 1984. He called it the big disease, but it all begins with NMO, like an inflammatory disease of the spinal cord and the optic nerve. He said that it was recurrent and generally in women. Next, please. Next. Well, in the timeline, we had the 1999 criteria for NMO with myelitis, optic neuritis, and an MRI without MS, multiple sclerosis lesions. So what happened next? In 2004, a landmark, an historical landmark, the discovery of the AQP-4 antibodies that are antibodies specific against the AQP-4 channel wáter in the surfaces of the cells in all over the body, but mostly in cells in the central nervous system. So in 2006, a new criteria for NMO, we request myelitis, optic neuritis, and an MRI without MS lesions as the 1999, but the AQP-4 antibodies. Next, please. So they discovered that there were other symptoms and signs that weren't in the 1999 and the 2006 criteria. So there was lesions in other parts of the CNS, of the central nervous system, NMO without optic neuritis or myelitis, monophasic disease in 10% of the patients, and they discovered that pathology was an astrocytopathy, like there is the astrocyte, and it was forming the blood-brain barrier. So the need to differentiate from multiple sclerosis, they meet the criteria. Next, please. Of the 2015. Next, please. So there, Wingerchuk and et al. In 2015, they need to create a new criteria, the broader for those on 1999 and 2006. Next, please. Okay, the NMO diagnostic criteria were at least one core clinical characteristic, positive test for AQP-4, and exclusion of alternative diagnosis that we will see next. Diagnostic criteria, no, previous, please. Okay, the diagnostic criteria without AQP-4 now in 2015 were available. So it is not necessary to have AQP-4 positive, because there were, or there are, a few laboratories that has the necessary equipment for dosing AQP-4. So in 2015, they said, no, if we had an MRI and clinical symptomatology, and we have the AQP-4 negative or not available, we could do the diagnosis as well. So patients without with other CNS symptoms, without myelitis or optic neuritis, a disease that could be monophasic in 10% of the patients. Patients with limited disease, like only mielitis, only optic neuritis. Patients with autoimmune comorbidities, no? Like lupus, Sjogren's, predisposed to have this disease. And they added some other abnormalities, other symptomatology in the NMO criteria, like Area Postrema Syndrome, episode of otherwise unexplained hiccups or nausea or vomiting, Acute Brainstem Syndrome that we will see, symptomatic narcolepsy or Acute Diencephalic Clinical Syndrome, and symptomatic cerebral syndrome. Next, please. So, the epidemiology, the NMO is a rare disease, less than 5 cases per 10,000 people. Caucasian has 1 in 100,000. Asian is a little bit more, and Black a little bit more, 10 on 100,000 people. Women are most affected by this disease than men, 9 to 1, way more. Middle age, around in the 40 years old, and has, like I said earlier, the relation with autoimmune comorbidities. Next, please. Okay, with the pathophysiology, the aquaporin-4 antibodies are against water channels located in astrocytes feet. The mu-inositol that denotes the function of the astrocyte is reduced. So it means that there is astrocyte necrosis. In the autopsy, an increase of the glial fibrillary acidic protein that explains the death of the astrocyte. So to sum up, autoimmunity against astrocytes. And sometimes there are lesions in deep white matter that is an aquaporin-4 free zone. So it could be coexistence of another autoantibody or another autoimmune disease different from the NMO. So they don't know, we don't know, so it could be any of these. Next, please. So to sum up, the aquaporin-4 antibody binds the astrocyte feet. It comes, the inflammatory cascade like any other inflammatory disease. Injury of the oligodendrocyte that is near of the astrocyte, demyelinating lesion, the neuronal death, and we have white matter and gray matter lesions. Next, please. So, signs and symptoms. Optic neuritis is the really most frequent symptom, but acute transverse myelitis is also 47% approximately. So, in optic neuritis, we have that it could be bilateral. In multiple sclerosis, it's really rare to have some bilateral optic neuritis. So when we have this bilateral, we have to think in NMO. It has severe loss of vision that MS don't have. Mild pain, that MS has really moderate pain. And afferent pupillary defect, MS has it too. Papilledema, MS almost always has it too. In MRI, more of the 50% of the optic nerve and affected of the chiasma. So MS doesn't have this. So it's really important to know this. And it has a poor recovery of the vision. This is so important because we have to treat aggressively from the beginning because then we won't have the opportunity. In acute transverse myelitis, it could be complete or almost always central. It could be tetra or paraparesis, sphincter dysfunction, sexual dysfunction, tonic spasms. In 50% of the people, is really difficult to treat. Pain, Lermite sign, sensitive level, and around, like I said, 47% begin with acute transverse myelitis. It has also a poor recovery. The Area Postrema Syndrome is one of the new discoveries and one of the most frequent symptomatology that we will see in NMO. And 9.4 to 14.5% begin with this. It's really comparing with the optic neuritis and acute transverse myelitis is really frequent. It has hiccup, nausea, and vomiting. Must last more than 48 hours. This is so important because if we have some hiccup, nausea, and vomiting less than 48 hours, we won't think, obviously, in NMO and other things, isolated or combined with other symptoms. Then we have the Acute Diencephalic Syndrome. We could have narcolepsy or non-narcoleptic hyperinsomnia, hypotension, overweight, hypothyroidism, hyperprolactinemia, galacturia, behavioral changes, all this because it is affected the thalamus and mesencephalic region. Symptomatic Encephalic Syndrome is the most inspecific symptom because any other symptom related with an affected encephalic structure could make us think about NMO. And Acute Brainstem Syndrome, we could have ophthalmoplegia, lower cranial nerve, like seventh nerve palsy, ataxia, vertigo, facial palsy, opsoclonus myoclonus, and always when we have opsoclonus myoclonus, we have to exclude NMDA encephalitis, and with the ptosis, the lower cranial nerve involvement, we have to exclude myasthenia gravis. Next, please. Well, we have here the longitudinal axis of the central nervous system. That is where the aquaporin-4 antigens are mostly. So it's here where we could find likely more of these lesions. In MRI, then, to do the diagnosis, we have the symptomatology, the MRI, and the serology. The symptomatology, we said it earlier. In MRI, 60% has accumulative injury on white matter. The 16% has lesions that meet criteria for MS. This is very important because the treatment in the relapse is similar, but the treatment of maintenance is very, very different. So include the neuromodulatory drugs. Only 7% has typical lesions of NMO, like lesions in the area postrema, periependymal surface of the fourth, third, and lateral ventricles, including lesions that are parallel to the corpus callosum. The MS has perpendicular lesions to the corpus callosum. Hemispheric white matter lesions, also gray matter lesions, and lesions at the corticospinal tracts. Let's see some images. Next, please. We have here the optic neuritis. bilateral, at the first image, the enhancement of the sheet, and then we have the chiasmitis. Next, please. Transverse myelitis. It's seen here, more of the 3 vertebrae enhancing if acute, and the atrophy of the spinal cord if it's chronic. Shorter lesions could be found until 20% of the people, but it is only make difficult our diagnosis. But if we have this and we don't think in MS, we could think the transverse myelitis of the NMO. Next, please. So the encephalic region is affected, like we said, like we see here in the 2 first pictures. An encephalic lesion that could be press or other thing. The lesions that are parallel to corpus callosum. We see here internal capsule affected and the area postrema also affected. Like we see in A, right, and also we see it B, C, D, E, F, all of the right pictures. Next, please. So the criteria and the comparison of the MS and NMO. NMO has longitudinally extensive lesion, more of or 3 vertebral segment, but remember, shorter lesions could be found. Central gray matter involvement, T1 hypointensity, common on acute lesions. The optic nerve usually has 50 or more % of the length of the optic nerve affected. We have the periependymal lesions surrounding the ventricular system, like 4, 3, or lateral ventricles. Hemispheric tumefactive lesions, lesions involving the corticospinal tracts. And this is very important, a cloud-like enhancing lesions. We could have myoinositol reduced, but we don't have the necessary equipment in the consult or in sanatorium or hospital to make the dosage of the myoinositol. Next, please. So the other part of the diagnosis, it's the serologic test. The aquaporin-4 antibody, it's an IgG. If we had the necessary equipment, we could dose it by cell-based serum assays. But if not, the sensitivity it's very much low that if we had it. We have to repeat if negative and high clinic level of suspect, but negativity must not delay the treatment, the acute treatment of the relapse. The OCB, the oligoclonal bands, could be positive up to 20%. And as we said it before, like 2015 criteria said it, another antibodies could be positive, like ANA, DNA, ROLA, SCL70, rheumatoid factor, anti-Jo, and RNP. Next, please. So, if we have the aquaporin-4 antibodies positive, we have a seropositive disease, and at least one core characteristic like transverse myelitis and optic neuritis. We have to exclude another diagnosis and does not require specific MRI images. But if we don't have we have the aquaporin-4 negative or not available, it is a seronegative disease, and we have to have at least two core characteristics. Area Postrema is one of the core characteristics since 2015. We have to have dissemination in space, but not in time, like multiple sclerosis. Exclusion of another diagnosis, like the seropositive, but it does require specific MRI images. So, if we have a seronegative disease, we have to have the optic neuritis, more of the 50% of the involvement of the optic nerve, or chiasmitis. Mielitis has to be extensive, 3 or more of the vertebra. Area Postrema Syndrome, lesion in the dorsal medulla, and the Brainstem Syndrome, lesion, as we said it before, at the peripendymaria region. Next, please. So, the red flags. If we had some of these red flags, we have to rethink the diagnosis. So, in ancient lesions, more than 3 months, this could be a neoplasm. Progressing disease, also cancer, sarcoidosis, in other lesions, other diseases. Spinal MS suggestive lesions, like less than 3 vertebrae. Worsening in less than 4 hours, like diencephalic, Area Postrema, mielitis, encephalic. All this could be ischemic or hemorrhagic as well. Partial spinal symptoms, this could be MS, more than NMO. OCB positive, less than 20% in NMO, but up to 80% in MS. And always have to think in HIV, syphilis, sarcoidosis, neoplasm. The CRMP5 mielitis is really difficult to differentiate from NMO. Next, please. So, here we have the prognosis. Kawachi, Lasman are researching this, and it's really nice to read because it clears all the field within the progressive or not progressive thing. So we have 10% are monophasic, aquaporin-4 antibodies positive are more likely to relapse. 60% at the first year could relapse, and 19% after 3 years. It is a lot. The relapse, we call it relapse when an event occurs after 4 weeks of the first event. Before could be the same relapse. Monophasic, we call it when there are new events after 5 years. So if we have inside within the 5 years another relapse, it isn't monophasic, it's already polyphasic and the most frequent form of the disease. And 50% without the treatment will need a wheelchair or will be blind at 5 years. This is awful. When there are relapses, the patient returns to his status, but more disability. So it's not a disease that is progressive. This is very important, and we see it at the graphic. Doesn't have para. Okay. Doesn't have para that MS has. Next, please. Sorry, I will be reading the questions later, please. So the treatment, we have the relapse treatment and the maintenance treatment. The relapse, we have to know that is very more disabling than MS. So we have to treat it aggressively. In the relapse, when we have symptomatology that is correct for NMO, we have the MRI, we have the AQP-4, we have to think on NMO. So we have to treat it. First line could be any which of the first methylprednisolone, 1 gram per day for 3 to 5 days, like MS. But if we have negative response after 5 days, we have to begin with plasmapheresis, 5 to 7 exchanges, alternate days. We could use together, yes. It's not very much studied, but we could do this if we have, for example, a very aggressive form of presentation. When I use plasmapheresis as first option, if we had good previous response in another relapse, if we have a severe relapse, or quotes mielitis, quotes we don't know yet, but we could use also plasmapheresis like first option before methylprednisolone. So mielitis could be an indication. So here we have some topics. The later we start treatment, the lower the percentage of remission. This is so important because like it says before, plasmapheresis could be beneficial until 90 days after the beginning of the relapse. But we have, if we start the treatment at 90 days, is very low capacity of the body to react better, no? So the patient that has a good response to plasmapheresis gets better by third exchange, almost in fourth or fifth day. Next, please. And the other part of the treatment, the maintenance treatment, we have some. After methylprednisolone pulse, we have to make a tapering, like lowering doses in about 3 or 6 months with prednisone or meprednisone, for example, prednisolone, and lowering 10% of the dose per month. And then with the tapering of the methylprednisolone, we have some drugs that are on first line and second line. First line, we have the azathioprine, the mycophenolate, and the rituximab. The best of these is the rituximab, but also the most expensive one. The azathioprine is really good and really cheap, but it has some negative effects, collateral effects that we have to take care of. So before the beginning of the immunotherapy, we have to check vaccines, laboratory immunoglobulins and serology, HIV, syphilis, Hep B, and others. Get vaccinated for Hep B, pneumococcus, and influenza virus. So why we don't have to treat like MS? Because interferon, natalizumab, alemtuzumab, etc. can worsen relapse. So we have to think very much if we have to treat it like MS or like an NMO. Next, please. So in 2020, they discovered other treatments that here in Argentina, for example, we don't have those, but in other places already has. Inebilizumab, satralizumab, eculizumab, and tocilizumab. So inebilizumab, if you want it, you have to search the N momentum trial. It's an anti-CD19. Satralizumab, Sakura Sky and Sakura Star trial inhibits the interleukin 6, as tocilizumab in the TANGO trial, and the eculizumab in the PREVENT trial inhibits the C5 protein of the complement. Next, please. Here are the references. If anyone wants to search, I use a lot more, but this is the most important. Next, please. So this is my hospital when I received of neurologist. So I like to thank you, the organization of Brain Disorders Conference, the moderators, and well, always the questions are very much received, and I would like to discuss my patients and the other patients of you people, you doctors, when you want it.